sacrum. This is going to be our sacral anatomy. What do we need to focus on as far as sacral anatomy? The main points I want you to remember as far as sacral anatomy are the sacral promontory, which is the most uppermost portion, most superior portion found on the sacrum. It's also the attachment point of where L5 attaches to the sacrum via the L5-S1 joint. Sacral promontory. I want you to know the sacral foramina. There's typically 8 found on the sacrum. You can also identify those on X-ray. And I want you to also know the apex of the sacrum. That is the most inferior portion of the sacrum. Sacral cornu, body, and ala, and the superior articular process are great to know, but that's not what's going to be asked of you. The ones they will ask you about are the promontory, the foramina, and the apex. There are 8 foramina, typically. Your average patient. If we look at the lateral view of the sacrum, we can still identify the promontory. Promontory is still going to be the most superior portion. It comes to a point, which we can see on our x-rays very well. I still want you to know the apex of the sacrum is right here in the most inferior portion. It's where the coccyx attaches. You do not need to know the median sacral crest. You do not need to know the sacral horn. Good to know, but not required. You also do not need to know the superior articular process of the sacrum. Main points to remember once again are the promontory, the apex, and the sacral foramina. Promontory, apex, and the sacral foramina. For the coccyx, there's also an apex of the coccyx. That is the most inferior portion of the coccyx. The very point of that tailbone or coccyx is the apex of the coccyx. There are also typically 4 segments on the coccyx, but not always, but on average 4 segments. All right, when we talk about a sacrum and coccyx x-ray, the routine is always going to be composed of an apiaxial sacrum and an apiaxial coccyx. You will not see just an axial sacrum or just an axial coccyx. They're always done as a pair. So on a routine series, you'll do the apiaxial sacrum along with the apiaxial coccyx, and then typically you'll do a lateral sacrum and coccyx together. Sometimes they may ask for a lateral coccyx by itself, but I've never seen that done ever. Typically, it's done together as a lateral sacrum and coccyx together, because when you do a lateral sacrum, you're going to have the coccyx on there anyway. Key point to remember, though, on this right here, guys, you always do an apiaxial sacrum paired up with an apiaxial coccyx. And of course, there are different angulations depending on what we're looking at, but you're never going to do one or the other. They're always done together as a series. And talking about the apiaxial sacrum, key points to remember, of course, make sure you know those angulations between the sacrum and the coccyx. It's the most often missed question when it comes to apiaxial sacrum versus coccyx. For the sacrum, we're always going to have a 15-degree cephalic angle. For the coccyx, it's going to be a 10-degree caudal angle. So 15-degree cephalic angle for your sacrum, 10-degree caudal angle for the coccyx. That's your key points to remember on that. As far as the steering goes, you're going to be 2 inches superior to the symphysis pubis. That's for both the sacrum and the coccyx. The key aspect there, once again, is the angulation. Cephalic angle 15 for the sacrum, 10-degree caudad for that coccyx. And of course, you're going to utilize very tight collimation on those body parts because they're very small. The tighter that collimation, the more it's going to pop for you. Otherwise, if we leave that collimation wide open, especially on the coccyx x-ray, it's going to be very hard to see because the quality is going to go severely down. You need that very tight collimation to make up that fine detail of that very tiny part. These are always done supine. You're not going to be standing. It would not be possible. Two inches above the symphysis pubis, 15-degree cephalic angle for that sacrum. And what are we looking for on an actual apiaxial sacrum x-ray? We of course want to see the sacrum not foreshortened. That's why we add that angulation. It actually gives it more of a true aspect on the x-ray, allows us to see it in its more true size. We also want to clearly be able to make out the sacral foramina. Sacral foramina need to be completely visualized. On an apiaxial sacrum, we should not be able to see the coccyx. If we have centered correctly and angled correctly, the coccyx will be superimposed upon the pubic symphysis. The sacrum is going to be the star of the show here. There's going to be that apiaxial coccyx, like I just said. We're still 2 inches above the symphysis pubis. Only thing we're changing is the direction of our angulation, as well as the angulation itself. For the coccyx, that is a 10-degree caudate angle, still 2 inches above the symphysis pubis, with the hopes of elongating the coccyx, gives a better view of it. That's why we add that angulation. We want to elongate the coccyx and better visualize it. I've mentioned it, but usually most of the time when people come in for these x-rays, it's usually because they need to go to the bathroom and they're constipated. More often than not, that's why they're having pain down there. And there we have it, guys. Of course, what do we want to see? We want the coccyx free of superimposition, because with the other view, the coccyx is actually superimposed on the pubic symphysis. For an apiaxial coccyx, when we angle 10 degrees caudate, we free the coccyx of superimposition, we elongate it, and we collimate down to the part. Now, typically, we want that region to be free of gas and feces, but of course, that's not exactly always in our control. And like I just mentioned, most of the time, that's why they're in for that x-ray. You usually see that covering up that whole area. You'll see the really dark fecal material covering up the area. They're usually constipated. That's why they're having that pain in that region. Not always, but quite often. Keep in mind, once again, the most inferior portion of the coccyx is the apex of the coccyx. It's the very tail end of the tailbone. Tail end of the tailbone. Most inferior portion of the coccyx, the apex. I would write those down. You're likely to see those, the apiaxial versus the apiaxial sacrum versus the apiaxial coccyx, how those angulations differ, how the directions differ. Make sure you remember that. Right, for the lateral sacrum and coccyx, when we're doing them together, CR is going to be 3 to 4 inches posterior to the as-is. There is no angulation for the lateral. There's a perpendicular central ray. And we want to have the entirety of the sacrum and the coccyx demonstrated in a true lateral position. Now, typically in this position, much like the L5-S1 joint, lateral L-spine, you want to go ahead and utilize the lead strip behind the patient. Reason being, because you're penetrating a very thick area using a high technique that's going to clean up that scatter. It's going to help enhance your image quality overall, as well as protect the patient from all that excess scatter because you're having to penetrate such a thicker region of the spine and pelvis. Perpendicular central ray, 3 to 4 inches behind the as-is, posterior to the as-is. Not the crest. As-is is a little bit more interior. The crest is right on top, put your hand around. As-is is more interior pelvis. There we go. We want that lateral profile of the sacrum and coccyx center. We want to see the entire sacrum and coccyx on that x-ray from promontory to apex of the coccyx. Well, sacral promontory down to the apex of the coccyx. Just showing you another view there. That sacrum and coccyx is true lateral. It's going to be Most inferior portion is the apex of the coccyx. Promontory is right here, it comes to a point. There's our L5S1 joint, and the entirety of that sacrum in a nice level profile. All right, our SI joints. So SI joints, we of course on the AP axial want to be able to visualize both SI joints together. We're going to implement a very different type of angulation, that being a 30 to 35 degree cephalic angle. The 30 to 35 degree cephalic angle will open up both SI joints at the same time on the pelvis. If we're doing a perpendicular central ray, SI joints are actually closed. We utilize that 30 to 35 degree cephalic angle to open up both joints so we can see them side by side for comparison view in the AP position. We're going to put that central ray 2 inches below the as is. The star of the show here is utilization of that 30 to 35 degree cephalic angle with the primary purpose of opening up both SI joints in the AP view. Oh, one extra note on that. I'm sorry, guys. For males and females on this view, males and females do differ. So you have that range of 30 to 35. Males is 30, females is 35. Males 30, females 35. I apologize. It's really dark. That's when I missed that. It's hard to read. 30 for males, 35 for females. Do those different shaped pelvises that males and females have. All right, of course, what do we want to see? Once again, we want both SI joints. Even though we're about to do obliques that center on one, for the AP axial view, we're actually visualizing both open SI joints. Once again, we open those SI joints by utilizing that 30 to 35 degree angulation of that tube cephalic. That's what actually opens those joints up in that position. Otherwise, they are closed when we have a perpendicular beam. We also typically want to see the L5S1 joint open, and that angulation is going to open that joint up as well on the L5S1 joint space. All right, and then we can have our posterior oblique SI joints. Now, for this X-ray in particular, one thing to keep in mind is that we're always visualizing the SI joint on the side that is elevated. The side that is elevated is the SI joint that will be opened on these posterior oblique SI joints. We do not put an angulation on our tube for this X-ray. It switches from that first view. The way we open up the joint is by the obliquity of our patient. We're going to put that patient in a 25 to 30 degree posterior oblique, LPO or RPO. So if I'm in an LPO position, my right side's elevated, I'm looking at my right SI joint opened. If I'm in an RPO, my left side's elevated, therefore I'm looking at my left SI joint. Centering is going to be an inch medial to the elevated side of the as is. Main point to remember on this one is we go from an angulation to a perpendicular beam, but we oblique our patient and we open the joint of the side that's elevated. So a great question would be, if my patient is in an LPO position for a posterior oblique SI joint, what SI joint will be opened? You would say, what? Sorry. Did I lose y'all already? Okay, now on me?
Right side.
So if I'm doing an LPO position, what SI joint is opened?
Right.
If I'm doing an RPO position, left, because the side that's elevated is the SI joint that we actually open up, those posterior obliques. Always demonstrate the elevated side for SI joints. Of course, we center towards the elevated side.
These are something to accept, right? Normally, you'll the downside that's there.
That you're visualizing?
Yeah.
Typically.
Okay.
That's why it's important to remember on this view in particular, we're actually visualizing that side that's up. It's the joint that's actually opening up as a result of obliquing the patient. All right, and of course, we want to see the sacroiliac joint of interest completely open. We also want the ala of that ilium to not overlap over the sacrum. If the ala of the ilium is overlapping the sacrum, it tells us we have obliqued the patient too much. It means they're probably in a 45-degree oblique instead of that more 30-degree oblique. Once again, we are opening up the joint at the side that is elevated. Those posterior obliques for SI joints. Showing you another view, that same thing, showing you that SI joint, a little hard to see in that x-ray, very ugly x-ray, but we are visualizing upside SI joint and those posterior obliques. That's the end of the review. Any questions for the exam on Thursday? It's focusing on spine and pelvis, primarily. Do you have a question?
You said if the right side is elevated, the left side is open? Or like...
So for the SI joints, if the right side's elevated, the right SI joint is open. So for SI joint obliques in particular, the side that is elevated is the SI joint that is opened up. The side that is down is closed. For the apiaxial view, though, both joints are open because we angle towards the joints.
Okay. Thank you.
All right, guys, so use your time wisely. I'm going to be sitting right here working on your exam and review stuff. You have exercises and quizzes due by 3:30. You have corrections due by 3:30. You also have portfolio, matrix, multiple assignments. You have the rest of the class time to work on that. And of course, you have any questions, I'll be here if you need me. So use your time well. You have the rest of the class period before lunch. And let me know if you need anything. Yes? I'm good, thank you, though. I'm positive.
Oh, okay, so on a serious note, who asked the question?
Which question? Come on up. Is that an assignment X-ray?
No, it's your mistake.
Oh, it's a safe thing. Something they really use is different. I like that. Is it for unacceptable? I use that. I think it's a good one. Use a pelvis inverse. Thank you. Yes, just going to see before you leave today.